Hello Mediicos and welcome back to my channel once again. If you like this video, please share it with your friends and subscribe to my channel. Hit the bell icon so that you are the first one to get notified as soon as I upload the video. Okay, so today's topic is conjunctivitis. In simple terms, if you define conjunctivitis, it is nothing but it is the inflammation. Any itis is inflammation. So inflammation of conjunctiva is conjunctivitis. If you detailedly define it, then it is nothing but it is conjunctival hyperemia which is associated with a discharge. Now, this discharge can be either mucopurulent, watery, or mucus or purulent. Okay. Depending on the type of conjunctivitis. Like for example, if you see acute bacterial conjunctivitis, then the type of discharge is mucopurulent. Whereas if you see viral conjunctivitis, most of the times it is the watery discharge that you would see. Okay. So before going into the details, let us have a brief idea about the anatomy of conjunctiva. Right. So from the previous class, you already know that conjunctiva is nothing but it is a translucent membrane, right? Now, what are the parts of conjunctiva? You have three parts. The first one is your palpebral conjunctiva, the second is your bulbar conjunctiva, the third is your conjunctival fornix. Now, if you see the diagram on the right side, this is your eyelid, right? The upper eyelid, the lower eyelid, the cornea, then the sclera. Now that part of conjunctiva which is behind the eyelids will be your palpebral conjunctiva. So this is your upper palpebral conjunctiva, and behind the lower eyelid you have your lower palpebral conjunctiva. Then the part of conjunctiva that is over the sclera is your bulbar conjunctiva. This is your bulbar conjunctiva. Here is also your bulbar conjunctiva. Now this palpebral conjunctiva and bulbar conjunctiva are joined by your conjunctival fornix. Okay. So this is your upper conjunctival fornix, lower conjunctival fornix. Otherwise, you can call it as superior fornix, inferior fornix. Then the one on the medial side will be medial fornix and that one on the lateral side will be your lateral fornix. On the medial side is nothing but your nasal bridge, right? There you can see a small pinkish ball-like structure, right? That is nothing but the plica semilunaris and the caruncle. So you can say that on the medial side, the conjunctival cul-de-sac, that is your conjunctival fornix of the medial side, is broken by the caruncle and the plica semilunaris. Okay. Then the one on the lateral side will be your lateral fornix. So that was about the conjunctival fornix. Palpebral conjunctiva can be divided into a marginal conjunctiva, a tarsal conjunctiva, and an orbital part, right? So marginal conjunctiva is nothing but which lies just behind the eyelid up to 2 millimeters. After that will be your tarsal conjunctiva, and then you will have your orbital part which will connect the fornix and the tarsal conjunctiva. Okay. So if you see the histological diagram now, histologically each type of conjunctiva is having different histological pattern. Considering the marginal conjunctiva now. In the marginal conjunctiva, you can observe that you have about 5 layered of stratified squamous type of epithelium. Whereas in the tarsal conjunctiva, you have only 2 layers. The basal cell is a deep layer of flat cell and the superficial layer is the cylindrical cells. Whereas the fornix, if you see, and the bulbar conjunctiva, you will have 3 layered epithelium over there. One is the superficial layer of cylindrical cells, then the middle layers of polyhedral cells and a deep layer of cuboidal cells. If you consider the limbal conjunctiva now, this is more 5 to 6 layered of stratified squamous type again. Then this was about the epithelium. After the epithelium, you will have the adenoid layer and the fibrous layer. Okay. Now coming to the glands of conjunctiva. Just observe the diagram on the right side. So what are the glands of conjunctiva? You will have 2 types of glands, right? One will be your mucin secretory glands and then accessory lacrimal glands. Mucin secreting glands, what are they? They'll be the goblet cells, the crypts of Henle, and the glands of Mans. Okay. Now, what will be your accessory lacrimal glands? The glands of Crossi. Right. Accessory lacrimal glands will be present near to the lacrimal gland. So, this will be the glands of Crossi. And you will have the glands of Wolfram here. Okay. So, this is all about the basic anatomy of the conjunctiva, which will help you understand the further aspects, like when you see for the symptoms of conjunctivitis. If I talk about the palpebral conjunctiva, you should know where is the palpebral conjunctiva. If I say look into the bulbar conjunctiva for the sign, then you should know where is the bulbar conjunctiva. Okay. Now coming to the types of conjunctivitis. Types of conjunctivitis is usually asked as the first part of a long essay question. Okay. So they allot basically 2 to 3 marks for it. It is very important to know this. It is better if you represent in the tabular form like how I have shown you. The examiner gets a very good impression that yes, this particular student has is well versed with the types of conjunctivitis and he has beautifully classified it. So you'll get full 3 out of 3 if you present it in this manner. Okay. So the first type will be your infective type. Okay, infective type of conjunctivitis. Then the second type is your allergic type of conjunctivitis. The third is your cicatricial type of conjunctivitis, and the fourth is your toxic type. Okay. Yeah, under the infective type, based on the causative agent, you will have different subdivisions of infective type. So if bacteria is the cause, then you will call it as bacterial conjunctivitis. If chlamydia is the cause, you will tell it as chlamydial conjunctivitis. If virus is the cause, then viral conjunctivitis. Similarly, you have a separate entity, that is your ophthalmia neonatorum, and the last one is your granulomatous conjunctivitis. Okay. Bacterial conjunctivitis can be further divided into 4 types, that is the acute bacterial conjunctivitis, the hyperacute bacterial conjunctivitis, the chronic bacterial conjunctivitis, and the angular bacterial conjunctivitis. This is mainly depending upon the causative bacteria and the severity of the infection, how severe the infection is. Okay. The chlamydial conjunctivitis causes trachoma, the adult inclusion conjunctivitis, and the neonatal chlamydial conjunctivitis. Okay. The viral conjunctivitis, depending on the causative agent, can be divided into adenovirus conjunctivitis, which is further subdivided as epidemic keratoconjunctivitis, and pharyngoconjunctival fever. Then after adenovirus, you will have your enterovirus conjunctivitis, the molluscum contagiosum, and the herpes simplex conjunctivitis. Ophthalmia neonatorum is a separate entity and also an important short essay as well as a long essay question for you, which will be dealt in detail. Granulomatous type of conjunctivitis is nothing but your paranoid oculoglandular syndrome. Coming to the second type, that is your allergic type of conjunctivitis. Allergic type, depending upon the hypersensitivity reaction, can be a simplex allergic, which is subdivided into a hay fever conjunctivitis, seasonal allergic conjunctivitis, and perennial allergic conjunctivitis. Then the second type under allergic will be vernal keratoconjunctivitis, which is very important. Then you have the third type, that is your atopic conjunctivitis, the giant papillary conjunctivitis, the flictennular conjunctivitis, and the contact dermoconjunctivitis. The cicatricial type of conjunctivitis is further divided as ocular mucous membrane pemphigoid, Stevens-Johnson syndrome, toxic epidermal necrolysis, and the secondary cicatricial conjunctivitis. Then the last and the final type of conjunctivitis is your toxic conjunctivitis. Okay. I hope the classification of conjunctivitis is clear. If you have any doubts, please let me know in the comment section. We'll try to explain it in detail in the next class. Okay. Now, once you know the types of conjunctivitis, let's begin with the first type, that is your acute bacterial conjunctivitis. Okay, acute bacterial conjunctivitis is an important short essay as well as a long essay question. Just to confuse you, sometimes the examiner may ask it as write in detail about acute mucopurulent conjunctivitis. So in that scenario, don't get confused. Acute mucopurulent conjunctivitis is the other name or the synonym of your acute bacterial conjunctivitis itself. Okay. So what is acute bacterial conjunctivitis? It is nothing but it is characterized by conjunctival hyperemia which is marked. That means severe type. Okay. So marked conjunctival hyperemia with mucopurulent discharge from the eye is called as acute conjunctivitis. Clinically, you call it as acute mucopurulent conjunctivitis. The most common type of bacterial conjunctivitis is your acute bacterial type. Now, what are the common causative organisms? They are the Staphylococcus aureus, the Cockweak bacillus, the Pneumococcus, the Streptococcus. Okay. Sometimes your mucopurulent conjunctivitis can occur after an exanthemata like measles or scarlet fever. Okay. Now coming to the pathophysiology. So what actually happens is whenever there is bacteria through the infected material, for example, there is already someone who is having an acute bacterial conjunctivitis and you just came in contact with the person, you shake hands or something, then the infected eye discharge from that person may pass on to you. So once the infected material comes in contact with the eye, the bacteria will enter the eye. Now there it causes a inflammatory response of the eye. Then all the inflammatory factors are released. This causes the dilatation of the blood vessels of eye which leads to conjunctival swelling, redness, exudates and the discharge. Okay, so this is the basic pathophysiology. Now coming to your clinical features. In the clinical features, you will always have to write about the symptoms and the signs, right? So what are the symptoms? Symptoms are nothing but the complaints which the patient gives are your symptoms. Signs are the ones that you elicit. The ones that you see in the patient are the signs. Okay. So coming to the symptoms first. What are the symptoms? The first and the foremost symptom is discomfort and foreign body sensation. Now, why do you see this discomfort and foreign body sensation? Because of the inflammation, there is engorgement of the blood vessels, right? So, once the blood vessels are engorged, it will cause discomfort and foreign body sensation. Then the third symptom is your mild photophobia. That is nothing but difficulty to tolerate the light. Then you'll have the mucopurulent discharge from the eye. Because of this discharge, especially when the patient is asleep, when he gets up in the morning, there will be sticking of the lid margins because of this mucopurulent discharge. Now, sometimes the patient may complain of slight blurring of vision. Why? So, what happens is when there is mucopurulent discharge, the mucus flakes will come in front of the cornea. Cornea is actually a transparent structure, right? So the mucus flakes that come on the cornea will give you a slight blurring of vision. Then the last complaint the patient may complain of is your colored halos. Why is that happening? That is due to the prismatic effect of mucus which is present in the cornea. Okay, so the mucus flakes will act as a prism. So prismatic effect of that will cause colored halos. Coming to the signs. Now what will you see for? You will see for the flakes of mucopus. Where will you see for the flakes of mucopus? You will see it in the fornices. So fornices you already know. The medial fornix, the lateral fornix, the superior fornix and the inferior fornix. Okay. So flakes of mucopus can be seen in, this is your medial fornix here, the lateral fornix. This inferior fornix is shown here. Superior fornix, when you turn the eyelid upwards, will be your superior fornix. Okay, so in the fornices, you will look for the flakes of mucopus. Coming to the conjunctival congestion. So where will this be marked? This conjunctival congestion will be marked on your palpebral conjunctiva, fornices, and the peripheral part of bulbar conjunctiva. Okay, so this is your palpebral conjunctiva here also. Then this is your peripheral part of bulbar conjunctiva and the fornices. Now all this you'll have the marked conjunctival congestion. So this gives you the fiery red eye appearance. Okay, fiery red eye appearance. Remember it. It is also a viva question. The examiner will ask you if you get a case on conjunctivitis. Okay. Okay. So where can you see fiery red eye appearance? Okay. So don't get confused at that time. Just remember fiery red eye appearance is your acute bacterial conjunctivitis, where you'll see marked conjunctival congestion in the palpebral conjunctiva, the fornices, and the peripheral part of your bulbar conjunctiva. That gives it a look of a fiery red eye. Okay. So this congestion is typically less marked in circumcorneal zone. You can see the congestion is less marked here near the cornea, right? Whereas it is more marked over this part. So this gives it a characteristic fiery red eye appearance. What you will look for is chemosis now, that is swelling of the conjunctiva. After that you will see of about the papillae. Where are the papillae? So papillae you'll see that it is of very fine type. Very fine papillae are seen. Then petechial hemorrhages are characteristics of pneumococcal bacterial conjunctivitis. Petechial hemorrhages are small hemorrhages, pinpoint hemorrhages that will be seen in pneumococcal type of acute bacterial conjunctivitis. Now what happens is, because of the mucopurulent discharge, your cilia will get matted with the yellow crust. The last sign you look for will be the edematous eyelids. That is, your eyelids get swollen. So you call them as edematous eyelids. All this is about the clinical features. That is your symptoms and signs. Right, so a quick review. Symptoms, you look for discomfort, foreign body sensation, mild photophobia, mucopurulent discharge, sticking of lid margins, slight blurring of vision, colored halos. Whereas for the signs, you look for flakes of mucopus, conjunctival congestion, chemosis of conjunctiva, papillae of fine type, petechial hemorrhages, matted cilia with yellow crust, and edematous eyelids. Coming to the treatment. So what is the treatment? See, whenever you have to treat the patient, ideally what you do is you go before starting the antibiotics, you just go for a culture and sensitivity of the discharge from the eye. After that, you start the antibiotics. But the reports will take at least 3 days to come, right? So you have to start with the antibiotic. What do? You give topical antibiotics. Topical antibiotics like chloramphenicol, gentamicin, tobramycin, framicetin. These are nothing but your broad spectrum antibiotics, right? So how do you ask the patient to use them? You tell the patient, put one eye drop of any of the above antibiotic, whichever you have prescribed, into your eye every 3 to 4 hours during the daytime. And during the night time, what you do is you will ask the patient to apply the ointment. Okay. Why is it so that you have to give eye drop in the morning and in the night you give an ointment? That is to provide a full antibiotic cover, so that the early morning stickiness is reduced in the patient. Okay. Supposing these broad spectrum antibiotics are not effective, then you can go for your quinolone antibiotics. What are those? Ciprofloxacin, ofloxacin, gatifloxacin, and moxifloxacin, right? If patient does not respond, you will use the quinolones. Then this was about the topical antibiotics. The second thing you will ask the patient is to irrigate your conjunctival sac with sterile warm saline. That is, they'll wash their eyes with sterile warm saline once or twice daily. Okay. Now, this is contraindicated. What is contraindicated? Frequent eye wash. Okay. Once or twice daily, that is every morning and night, once or twice is recommended. But some people, when they get infected, they wash their eyes very frequently. So, this frequent eye wash is contraindicated Why? Because when they frequently eye wash it, your tears secrete an important enzyme, that is your lysozyme, which will act against the bacteria. So the lysozymes and other protective proteins which are present in the tears will also get washed away. So always tell the patient, do not frequently eye wash, just use sterile warm saline once or twice daily to irrigate your conjunctival sac. Okay. Then the third step is you ask the patient to wear dark goggles. Why? To prevent photophobia. Okay. Then no bandage should be applied in patients when there is mucopurulent conjunctivitis, because exposure to air will keep the temperature of the cul-de-sac low. This will inhibit the bacterial growth. Whereas when you bandage it, the conjunctival sac will get converted into an incubator. So the infection will flare up to a severe degree within 24 hours. Therefore, bandaging should always be avoided. And if you bandage, the other thing is the eye discharge, whatever is happening, that will be prevented from getting escaped out, right? So those are the two reasons why you should never bandage an acute mucopurulent conjunctivitis eye. Never ever give steroids. Remember, no steroids at all. No steroids. Because if you give steroid, the infection will simply flare up and the bacterial corneal ulcer as a complication may occur. Then the last step is giving your anti-inflammatory and analgesics drugs orally for at least 2 to 3 days. Now what can you give? You can either give ibuprofen or paracetamol. Why? Because it will give us symptomatic relief from mild pain and discomfort which is present in sensitive patients. Okay. Coming to the complications now, occasionally acute mucopurulent conjunctivitis may be complicated by superficial punctate keratopathy or marginal corneal ulceration or superficial keratitis or blepharitis or dacrocystitis. Each of this is a separate short essay question and will be dealt in detail in the chapter of cornea, eyelids. Okay. Now what happens if you don't treat the case? Suppose there is acute mucopurulent conjunctivitis and the patient has not turned up, thinking that it will resolve by itself. So if the infection is mild, the patient may overcome it. If the patient is cured in 10 to 15 days without coming to you, it's okay. But if it is not cured in 10 to 15 days, then it passes into a less intense form, which is nothing but your chronic catarrhal conjunctivitis. Is it clear? If you have any doubts, please let me know in the comment section. I'll try to clarify those. And this is all about, acute mucopurulent conjunctivitis. Our next class will deal with trachoma. Trachoma is also very important long essay question. So thank you. Thanks for being with me.